So, good evening, everyone. Welcome to our Discover Medicine session. First time, first and foremost, I would like to acknowledge for everyone who is there here on time. This again is a session which is planned not in the routine hours, and you, the students and doctors who are willing to go through this, you know, session, spending your time here. Uh, it really needs mention and acknowledgement. Thank you for being that kind of a person. Next thing is, I would like to address few concerns that we may have. Given that this is an online medium, the session may encounter some issues like the network. If there is an issue with network, it may take a minute or two for me to show up again. So kindly hold on if that happens. Yeah. And the next concern that is there is uh, last in the last session that we had, we you have an option to ask questions through chat, right, in the live session. But the chat shows up with a delay of maybe 30 to 40 seconds. So what I would recommend is, if you have any questions, as we go through the session, if you are finding any, okay, this is a doubt which I need to clarify, have that typed in now only, so that when I come back again, so you don't have to spend time. Otherwise, we will lose time on that aspect. So what will work is, if you have a question, then keep typing it in between. Okay. So today's session, I have titled it as discovering the boundaries, like I would rephrase it again, discovering your boundaries in the universe of blood pressure. So this topic of blood pressure is the universe. This in this session, I have one promise, and the one promise only is that you are going to be powerful. Now, you are going to be powerfully skilled to dwell and live in the universe of blood pressure. What I'm not promising is the complete knowledge about blood pressure. It's a universe. You can't cover that in 1 hour. Obviously not, right? So what is going to happen is, you're going to be developed in like some of the things that are not commonly discussed in the bedside rounds, or you may not find your attention to when you're reading, or when you're learning new stuff. What may not catch your attention but are very relevant either in your clinical practice, or when you're dealing with the subject of hypertension, those things are going to be addressed in today's topic, right? So we will not waste any more time. So I will start sharing the screen now. um, so I have told you, like, this is universe of blood pressure, and in that the clinical relevant thing is hypertension and hypotension. I'm not going to use this session to again reinforce the commonly found topics, either in book or which is commonly discussed elsewhere. But I'm going to share with you things that will make it easy for you to register, recall, and reapply. So the first thing is we are addressing is the causes of hypertension. If you have been following us over the past few sessions, there was a video called Discover How to Answer Anything. If you have not watched it, I would recommend you watch that video after this session. Okay. It's a strategy for you to technically answer anything, either in your theory or clinical bedside rounds, but also it is a strategy for you to really make benefit for patients. Like, when you're diagnosing patients, having a structure will help you. And this structure I have shown again to find out the cause of hypertension. Again, this video is going to be there with you. The screenshot, you can take it and have it for you. I have no copyright, anything like this for this screenshot. So, but I would like to bring to your attention a few things. Again, the if you're not attending the session, we are using all the these are the headings under which we are going to strategize and find causes, right? And in this session, what I've done is, excuse me. So what I've done is I have rearranged. Usually the idiopathic as the cause shows up in the last when you're strategizing a cause. But for hypertension, usually you start with something called as what is the most common cause. 90 to 95% of them, you will call them as primary or essentially hypertensive. Okay, and in them there are no causes. Like, mostly it is believed to be hereditary. which is like inherited again, but if you want to say like this is the cause, there is no known cause. Like that's how you will define either it's a primary or essential hypertension. Okay, and when you're coming to the inherited, or should I say like if you are proposing a hypothesis, like if we don't know like what else could be still involved in causing hypertension, what you will go for is hereditary. And the mechanism is the body's blood pressure is going to increase over a period of age. Like year by year, your body has a tendency to raise its blood pressure, and the mechanism behind it is the retention of sodium. When your body, the salt retention, especially the sodium chloride retention, if that happens over a period of time, it occupies its place in the outside the vessels and start building pressure. That's how your body blood pressure increases. That's a hypothesis which partially explains possibly idiopathic ones also. Okay, so what I would draw to your attention is you look at, like I have highlighted it, like chloride, because non-chloride salts of sodium have little or no effect on blood pressure. So the common salt that we use, that is the direct, etiology. That is the direct thing many would recommend for you to target if you are dealing with a patient. Either you want to reduce the blood pressure of the patient, or you're looking at what would make a difference. That would be a sodium chloride, the common salt. Okay. And next thing is there is a mechanism called renin angiotensin aldosterone mechanism, or a renin angiotensin aldosterone system, which is a body's mechanism. Many times it is a protective mechanism to retain volume in the body, to retain the intravascular volume. That needs little bit mention. I have made a separate slide for it in the next slide. So you need to get to that. And infiltration, like any tumors which are involved in renin-angiotensin aldosterone mechanism. When you are saving it as a screenshot, I said this is a structure for you to build n number of causes. I have just built renin secreting tumors, but there can be other tumors which are secreting aldosterone or angiotensin also. They also can be included under the heading infiltration. Okay, so it need not be a benign or a malignant tumor of renal origin only. The tumors could be in the distant lungs, like organs like lung, liver, pancreas, etc. Even then, there is a chance of that contributing to causing a hypertension. Okay, so apart from the primary and essential, rest are all the causes of secondary hypertension. Next is the iatrogenic. This is one special mention, beta blocker, which is used to treat hypertension, can cause hypertension, especially like not especially in a patient with pheochromocytoma. Here, what happens? There are too much of catecholamines, or the chemicals that are willing to raise the blood pressure. They are like in effect to raise the blood pressure, and they are mediating their mechanisms through the receptors called alpha and beta. Well, I'm not going to go in detail of it, but this needs special mention. So they are mediating their effect through alpha and beta receptors. In a beta receptors, there's a class of receptors which are antagonizing the effect of these chemicals. So when you use these beta blockers, what you're causing is a unopposed effect of alpha receptors that can tremendously rise blood pressures. Okay, so that's why special mention I've made of beta blockers used in pheochromocytoma, that as a cause of hypertension. And the irrelevant is cerebral vascular accident. So we are not only dealing with the renovascular or cardiovascular as a cause of hypertension, even the cerebral insult can result in hypertension. Infections, inflammation, and immunity. These things which show up as cause of many number of medical topics that you will discuss, they find their place on the lower down when you're talking about hypertension. Remember, it's hypertension is a non-communicable disease. So the infection, they cause an acute stressor. They can increase blood pressure. In later stages of sepsis, they may cause fall also. But they are not commonly counted as a common cause of hypertension. The inflammation, immunity, well, they cause, but again, they are less common. So that's why they are. And the mechanism by which they will cause hypertension is by damaging the endothelium, which maintains the balance between the endothelial stability and the vascular contractions, the vessel contractions. Okay. So this is what I was talking about. I am not going to go through the whole slide. Just follow the arrow. So whenever there is a decrease in blood pressure, the kidneys, they produce renin, mainly the juxtaglomerular apparatus. When they produce renin, next thing is it follows just the name of the axis. Renin produces angiotensin 2, which when it's activated, they will produce aldosterone, which is an antidiuretic hormone. Tries to retain volume. Remember, So when there is decreased blood pressure or a volume, kidneys produce renin. Renin produces angiotensin. Angiotensin, mediates through aldosterone, and what they do is, they will increase cardiac output and cause peripheral vasoconstriction to increase blood pressure, as well as they are basically causing sodium and water retention. They are also called as mineralocorticoids. They're going to retain the minerals, sodium and water retention. This is what their function, and they will try to achieve homeostasis. Well, this is what happens in a normal condition, but over a period of time, especially in hypertensives, this is the mechanism that is addressed to cause the hypertension in many. After you have gone through the 90 to 95% unidentified, the rest of the 5%, in that majority have a renal disease, and the mechanism that explains is renin angiotensin aldosterone mechanism. Okay, so they deserve the place of mention in the slide. Okay, so now let's get into something more interesting. Have you heard about this anytime this year? Measure your blood pressure, control it, and live longer. Well, if you have been caught up with too much of news about COVID and Corona, maybe you have missed it. So this is the WHO theme for World Hypertension Day. Sorry, not the WHO thing. I apologize for that. World Hypertension League. They have been celebrating a day called World Hypertension Day since the year 2005, and each year has a theme. And this year's theme is this one: measure your blood pressure, control it, and live longer. Two things I want to say about this. The first thing is I want you to notice I have highlighted the word "your." First, let's talk about the day. Why it is there? It is to create awareness. Well, all doctors knows there is a condition called blood pressure, hypotension. So, who is this theme referring to? It's for the general public. And what are they saying this time? Measure your blood pressure. Well, like if someone is talking to you, they are not going to tell measure your blood pressure, right? As a doctor, they would say like measure the patient's blood pressure. But this theme says measure your blood pressure. So this theme is directly talking to patients or the general public, and it is asking them to control it and live longer. You know, um, and again, if you're caught up, you have not got time to get aware about it. I said we are going to stretch the boundaries, like your boundaries. You're going to in this session you're going to encounter your boundaries that limits you living powerfully inside this universe of blood pressure. So every year, 17th May is dedicated to World Hypertension Day, and this is the initiative of World Hypertension League, as I mentioned earlier. But the thing is, this year it has been postponed to October 17th due to global COVID-19 pandemic. So just like you and I are caught up, you and the Hypertension League is caught up. It's a day to celebrate, not to be stressed. So they don't want to have celebration at the time of pandemic. So that's why the new date that they have announced is October 17th. So this year's World Hypertension Day is yet due. Okay, so last year we have another YouTube channel again created for medical students and general public. There was a hypertension video awareness that was created, which will be a worthwhile watch for both medical students and general public. So I'm going to play that now. It's a short video.
Hello everyone, welcome to Creative Med School. I'm Dr. Pragati Vadkar. This video is created by Healthy People Happy Doctors to create awareness about hypertension. What is the need for creating awareness about hypertension? Well, allow me to explain. Consider that this circle indicates the total number of individuals living with hypertension in a community. Only half of them know that they have hypertension. The other half are not even aware that they have hypertension. In those who know they have hypertension, only half of them receive treatment. The other half end up not getting treated for various reasons, including lack of awareness. In those who are on treatment, only half of them will have their blood pressures under control. The rest of them still remain as uncontrolled hypertensive patients. So, we can see that only a small fraction of hypertensive patients end up receiving any meaningful treatment. Many a times, hypertension goes undetected due to lack of awareness in the general public. So, it becomes crucial for the general public to know about the risk factors and the possible symptoms of hypertension. Let's know what are the risk factors for hypertension. The common risk factors are diabetes, smoking tobacco, consuming junk foods with excessive salt, high caffeine intake, lack of exercise, and nowadays living in a stressful environment. In many individuals, hypertension causes no symptoms and hence it is called a silent killer. However, headache, blurring of vision, bleeding from nose can be early indicators of hypertension. If untreated at this stage, patient can end up having a heart attack or a fatal stroke. So, if you are someone who has any of these risk factors or someone who has experienced any of the symptoms of hypertension, then immediately reach out to your doctors and know your numbers. Kindly share our video with your near and dear ones to create awareness about hypertension and help us catch the missing halves. Thanks for watching this video. See you soon with another video.
So well, so I guess you like the video. So two things again from that video, that as a medical student, one is the rule of halves. So you saw the, if you really got present to the enormity of the disease burden on the community and the amount we are reaching out to, it's very bare minimum. Okay, and you'll also discover over a period of session how we are actually even missing, even in the community that we are okay to serve, like we are reachable. Even there, we are doing a lot of stuff which may need some rectifications. Okay, so and the other thing is it's also called as a silent killer, and there was a theme of last year, know your numbers. So that again was addressed for general public. So let's begin with defining hypertension. See, traditionally it is taught as okay, hypertension is systolic blood pressure more than 140 and diastolic blood pressure more than 90. Okay, so no, that is not the start definition to start with. So let's look what is actually hypertension. So clinically, hypertension may be defined as the level of blood pressure at which the institution of therapy reduces blood pressure related morbidity and mortality. So please focus, it is not reduces blood pressure. It reduces blood pressure related morbidity and mortality, right? Um, if you compare this with a fever and paracetamol, see, you define fever in a different way. Like a body temperature elevated, you give paracetamol, then it decreases. And a normal temperature patient, if you give paracetamol, the temperature doesn't decrease, right? There you can define fever based on medication like that. But in hypertension, it is not the same. You give a antihypertensive agent, the blood pressure decreases, but that doesn't say that he's a hypertensive patient. It has to reduce the morbidity and mortality associated with blood pressure, and that is what actually the original definition of hypertension would be for a clinician, right? Now, how to find that? There is a lot of researches have been done, studies have been done to get the number so that you can use it. Now that is where the number come into play. Not the direct definition shouldn't be like, I would recommend you directly use it. It's 140 90 as the direct definition of it. Okay. So now coming to the criteria, how to diagnose hypertension as a clinician, not the definition. The criteria to diagnose hypertension. So again, I would like to introduce you to a word called office hypertension or office blood pressure and home hypertension or home blood pressure. Okay. What is recommended is that you get as much of readings to diagnose a patient with hypertension. Many see once you are diagnosing a patient with hypertension, it's like you are sealing him, like on his head you have stamped that he is a hypertensive patient. So if you're less cautious and you're just at your you fancily just okay one reading and it's above and you will start labeling them as hypertensive patients, you may be causing more harm than good. you know but despite but still we have so much of limitations that we can't do for everyone, but whenever it is possible, see that you follow what is recommended. Okay. So first thing is you're going to diagnose based on the criteria which says 24-hour blood pressure monitoring, and in that average awake blood pressure should be more than 135 by 85 millimeter of mercury, and the average asleep blood pressure is more than 120 by 75 millimeter of mercury. And you see like how the definition is so strict. It says and, it is not average awake or, it's average awake and average sleep. Okay, so these are the numbers. I recommend many students to use only the even numbers when you write the blood pressure, given that we use sphygmomanometer ordinarily even now. But the target is mentioning odd numbers. So don't worry about that. This is the target, and what you're going to still mention is the even numbers whenever you're interpreting the blood pressure measurements to someone else who's listening to you. Okay. And so this is the note here. This is what actually you're watching. These levels approximate a clinic blood pressure of 140, 90, 140 by 90 millimeter of mercury. So what it says is when you are measuring the blood pressure for the first time in the clinic, and if his blood pressure is above 140/90, that usually is indicating that patient's average awake blood pressure must be 135/85 and average asleep blood pressure must be above 120/75. That's what this is indicating. But traditionally bedside, this is what is discussed and said from generations to generations. But I want you to really dismantle that the routine way of defining hypertension and the way of practicing. Okay. Next thing, home blood pressure and average 24-hour ambulatory blood pressure measurements are generally lower than clinic blood pressures. You may say it is anxiety or the patient's preparation. See, when you measure blood pressure, there are lots and lot of details to be taken care of. They are simple, but the detailing is uh, uh, really there are many things to take care of. The patient should not have smoked immediately, or should have not walked and climbed stairs. He should have rested for a few minutes, and should not be talking. Even like should not be talking when the blood pressure is being measured. So many of the parameters that are there for you to obtain a proper clinic blood pressure, right? Many times that are not followed. And other thing is patient who is coming to you may be anxious, like what's going to happen to my reading. If and these are just the possible explanations. These are not the only explanations. And whatever the reason, now this is what ultimately the patient is going to have. When you are going to measure his home blood pressures and average it, the overall blood pressures, you're always going to find a lower level, mostly, than the clinic blood pressures. Okay, and that gives rise to two terms. One is the white coat hypertension. So white coat is obviously like our symbol, something which we are proud of. So this white coat hypertension is like when patient comes to you, only that time he is hypertensive. Interesting, like again the parameters again, like maybe the way you measure, the way the patient was prepared, or just the pure anxiety related one, whatever the reason could be, the patient has high office blood pressure and low home blood pressure, and that would be fit into white coat hypertension. Okay. So I mentioned something about the stage. Again, you can take a screenshot of it. Stage will be, I will discuss different stages of classification in the coming slides. Next thing is the masked hypertension. Here the reverse happens. There is normal office blood pressure and elevated out of office blood pressure. Again, it's not impossible. Like that is possible. Well, less frequent, but it is possible. So something which you need to be aware of. Again reinforces why you need to have as many readings as possible before labeling someone as hypertensive patient. Okay, and this is again interesting, and which may make you rethink the way you will diagnose hypertensive patients. Some authorities recommend ambulatory blood pressure monitoring in all individuals. You see here, the word you need to focus is they recommend. They're not saying you should. They say it's recommend, and monitoring in all patients with elevated clinic blood pressure. You know, and there's another one which says in untreated or treated subjects, like someone who is hypertensive, you're treating them, or someone who has come for the first time, and your office measured blood pressure is falling into high normal blood pressure or grade 1 hypertension, then the BP level needs, it's not recommended, like they need to be confirmed using home or ambulatory blood pressure monitoring. I know there are so many challenges in doing this, but you need to be aware what needs to be done in real hand, so that for whom it is possible, for them we need to take care of them like the way it is needed, right? Okay, and you also can observe this, like they're asking you to postpone therapy and carefully follow up. See, you label hypertensive, the whole cost burden, everything, the game changes for the patient. Now he is going to live his life as a hypertensive for the rest of his life. So before you label him, see that if the opportunity is there, you're doing it the right way, the way it is meant to be done. Next, diagnosis. Oh, then you're asking like, oh, then how can I diagnose the patient at the first time? Like, it came to me and I measured his blood pressure in the clinic, but can I still make a diagnosis of hypertension in such patient? Yes, you can. Again, the criteria for that is very strict. You need to have a blood pressure at the first visit, or that single visit that you're talking about, of more than 180 systolic and 110 millimeter of diastolic blood pressure, millimeter mercury of diastolic blood pressure. And not only that, and there is evidence of cardiovascular disease. So you can go refer to the standard books that are there. Okay, so you will find these uh, lines which I have placed to you as accurate as possible from the standard books that we commonly practice. And none of the things are saying just be liberally and have them added to hypertensive group. So you have to look amount of clarity that is there in the book and how much of unclarity we live with. 180 by 110 millimeter of mercury and evidence of cardiovascular disease. That is how you will diagnose a patient as hypertensive if you want to do it in one visit. Okay, so now let's get into some more definitions. Malignant hypertension. So that is the definition that is there. Abrupt increase of blood pressure in a patient with underlying hypertension, or relate to a sudden onset of hypertension in a previously normotensive individual. Now that is what has to happen. Either abrupt increase has to happen, or there has to be a sudden onset of hypertension. And next thing is, this is again is mentioned in standard books, the absolute level of blood pressure is not as important as its rate of rise. So if someone is asking you at what level would you diagnose malignant hypertension, well, that is not important. You're going to look at the whole course and the rate of rise. But still, there are many examiners who would want to hear a number from you. And for them, you can, I will tell you the answer for that also, right? So clinically, how you're going to diagnose malignant hypertension is the syndrome is recognized by retinopathy, renal function deterioration, microangiopathic hemolytic anemia. See, I have bolded microangiopathic hemolytic and anemia later, given that here the anemia is being caused by the hypertension. Like there is vessels have been shrunken due to fibrinoid necrosis pathologically, which you can see, and those shrunken vessels are now receiving bloods at higher rates, which are damaging the RBCs. The pressure is pushing the RBCs, squeezing the RBCs through these narrowed caliber vessels, and that is causing anemia. So you don't include any anemia. It has to be microangiopathic hemolytic anemia. You have to find evidence of hemolysis to diagnose a case of malignant hypertension, right? And encephalopathy. So these are the criteria which will let you know how to diagnose a patient with malignant hypertension. Okay, and pathologically, you will find fibrin necrosis. This is a characteristic finding for a patient with malignant hypertension. So when you are looking at the arterioles, you open the biopsy of renal biopsy or liver biopsy, and you look for arteries. You will find fibrinoid necrosis of the arteries. Okay, so here it gives rise to some other definitions. So let's see what is hypertensive urgency. So you can see the numbers: systolic blood pressure more than 220 millimeter of mercury, or it's not and, okay, or diastolic blood pressure more than 120 millimeter of mercury occurs in the absence of acute end organ damage. So blood pressure is going to damage your and what we call as end organs, like the brain, heart, peripheral vessels, um, kidneys, right? So out of this, there are no organ damage, but the blood pressure is elevated. You know, there are some sources which mention the systolic blood pressure as 180 millimeter of mercury. Um, so there is some controversy about that, but still you can hold on to this number. If this doesn't work, maybe you can use the other number if that satisfies your examiner. Okay, dash blood pressure remains the same. It is more than 120 millimeter of mercury. So you need to focus hypertensive urgency. So there is another definition called hypertensive emergencies. So urgency and emergencies. So there are multiple conditions inside of it. Here the systolic blood pressure is more than 180, which some authors use for this, right? 180 millimeter of mercury, or diastolic blood pressure is more than 120 millimeter of mercury. But this includes presence of acute end organ damage. Please also note it is acute end organ damage. So a patient who had myocardial infarction maybe a year back, uh, he will have to show some acute evidence for that to be classified as hypertensive emergency. Otherwise, you can be dealing with just uncontrolled hypertension. For example, blood pressure of 160 by 120. Well, you're just dealing with a simple uncontrolled hypertension rather than a hypertensive emergency. Okay. So now again, this brings to a little bit again back to malignant hypertension. So malignant hypertension and accelerated hypertension, they also have definitions. First thing is they are a type of hypertensive emergencies. Both are emergencies. And malignant hypertension, as per definition, classical definition, they should have papillary edema. Without that, you should not be diagnosing malignant hypertension. But recently, they have come with new definitions, which says because patients still are having features which are consistent, outcomes which are consistent with malignant hypertension despite treatment. And for them, they are saying that okay, if you don't find papillary edema, at least find three different organ damages. Okay, and even them, like when they have this, they also can be included under category of malignant hypertension. Or you can use another term called accelerated hypertension, where there is no papillary edema and it is recent increase over baseline. So the difference here is the patient comes to your first visit and you see everything there, including the number of numbers saying it is hypertensive emergency. You can possibly diagnose a malignant hypertension. But for you to diagnose accelerated hypertension, you need a recent increase. So that means you need to have a baseline. You need to be aware of the baseline blood pressures, either to documents or your own follow up to diagnose accelerated hypertension. Other way, it is like you don't have a papillary edema. I think that slide really clarifies the questions which have become an adage for many many students, which they will keep hearing. I think that slide really helps. So I really enjoyed actually having putting that slide and discovering the differences that were there. Other factors to consider, like when you're measuring blood pressure, there are some other factors that you need to consider. Blood pressure tends to be higher in the early morning hours, soon after waking up, than at other times of day. So how does this play out for your practice? So if a patient comes to you in the morning hours, mostly some patients who are diabetic, they also come to you for counseling. When you are available in the morning hours, what happens is that they come at morning 6 o'clock to get fasting sugar or 8 o'clock, depending on the clinic timings. After that, if they come to you for blood pressure measurement, you may falsely find a high blood pressure. And also, like we already discussed, how unprepared many times the patients are, you may tend to overdiagnose hypertensive patients. Okay, and the same way, if you are measuring the nighttime blood pressures, there is generally 10 to 20% lower. So if you are again clinic, you are having all the evidence. It says the patient is maybe having uncontrolled hypertension symptoms features, and when you measure blood pressure, this need to be in the background that you may be measuring a falsely low blood pressure in such patients. Well, we are going to again discover our boundaries. So the boundaries that you're going to discover, if you already are not have not crossed it. First thing is convention. You are measuring blood pressure in right hand by convention. That is what was answered and accepted for many years, but no longer. Whenever the blood pressure of the patient to be measured, you need to measure it in both arms. And if there is a difference of more than 10 millimeter of mercury, you need to repeat the measurements. And if there is a difference of more than 20 millimeter mercury, then you have to evaluate. It can't be just normal finding. Okay. And a few more things which I think students miss out. Blood pressure, the best position to measure blood pressure is not supine position, but sitting position. Many students answer it as supine position. No, sitting position is the best assume. If not possible, then you are choosing the patient's supine position. And the next thing is your whatever the apparatus you're using, that needs to be in heart level. That is both same for supine and sitting position. Regarding the usage of bell and Kortokov sounds, well, I will try to cover them in some other sessions. So, given that for the limitation of time, and I'm going to give only the things that will, help you cross boundaries and be powerful, we will not be discussing much about Kortokov sounds and and their mechanisms in this session. Um, well, to make it simple, you can measure blood pressure using diaphragm, but Kortokov sounds, there are articles which say you need to use bell. Either of them have been okayed, and they're not much difference. Either you measure with a bell or a diaphragm. That's with regard to measuring blood pressure. And there is one technique which you will use sometimes for a patient who is on treatment, or someone who you are measuring the blood pressure based on symptoms, especially when they are presenting with symptoms which suggest orthostatic hypotension. So in them, the position is not supine or sitting. You are going to use the standing also. Like you're going to sit, patient is going to sit or in supine position, and then you're going to measure the blood pressure. After that, you're going to ask the patient to stand and then measure the blood pressure again. Well, I have not put the definition here. I apologize, but what it says is sustained, decrease in blood pressure of more than 20 millimeter of mercury. That's when you define orthostatic hypotension. Well, so it doesn't say. If you look at the technique, what is usually recommended is patient supine position. You measure the blood pressure. You're going to ask the patient to stand, and then you're going to measure the blood pressure at the end of 1 minute and at the end of third minute, so that you find a sustained decrease in blood pressure. Well, this may not hold good all the time. Imagine the patient is actually orthostatic hypertension patient, and you measure the blood pressure in supine position, and you ask the patient to stand, and the drastic blood pressure that let the that can happen if the patient succumbs, or if the patient collapses on standing, like not able to stand, then what are you going to do with that patient, right? So I would say, like in clinical practice, how you may need to apply is you're going to ask the patient to stand and immediately measure the blood pressure, and if possible, more frequently than at 1 minute and 3 minutes. Just to first thing is to whether it fits into the sustain. See, if there's a drop and it did not sustain for 3 minutes, that doesn't classify as orthostatic hypotension. The same way, if the BP drop was there, and because patient was unable to stand, and you can't measure, that can't be, you may be missing a patient with orthostatic hypotension if you're doing only this strictly. Again, all the recommendations are just the suggestions. It doesn't outweigh your clinical judgment. Okay, this is the class of hypertension that I was talking about. Again, you will find this in many. So normal blood pressure is systolic blood pressure less than 120, and this is what I wanted to highlight in this slide, and diastolic blood pressure less than 80. And I also want to bring to your notice that in the whole classification, apart from this normal which has and, everything else has or. So either in pre-hypertension or stage 1 hypertension or stage 2 hypertension, the patient need not have elevation of both systolic blood pressure and diastolic blood pressure. They can have elevation of either one of them to classify them as hypertension. Is this important? Yes, it is important. You know. So I will tell you why it is important when we are discussing a little bit on treatment. So let's get to the treatment recommendations. First thing is it doesn't do justice if I don't reinforce this again. Hypertension patients are missed, and those who are diagnosed many times are falsely diagnosed. Because of the incorrect measures that we do. And this how it is going to impact treatment is by this way. The relationship between naturally occurring blood pressure and risk is linear down to very low blood pressure. So there are many studies which have confirmed that the lower the blood pressure, the lower the risk of blood pressure related morbidity and mortality in patients. Simple. In fact, these studies are there. Even those studies you can logically interpret. Yeah, less blood pressure. How will less blood pressure will cause blood pressure related morbidity and mortality, right? But you can't use this logic to treat. Oh, so I am having a blood pressure of 120/80. So let me try to reduce my blood pressure to 100/60 and try to find out if there is any morbidity and mortality benefit. Well, that is not there. So if a patient's average blood pressure is 130/90 and you're trying to diagnose him as hypertension at one visit, one visit of clinic blood pressure, and you started him on medications, you're doing no benefit. And in fact, my logic and what I suggest to students is practicing medicine is knowing when not to give medicine. Okay, so if you're like, oh, 140/90, it feels good to write a medicine tablet and I'll write it and give it to the patient, don't do that. Especially, growing as an intern or a medical student who is visited by sometimes relatives, right? So hold on. You don't really cause a damage on that visit. The damage happens if you're not able to follow up with the patient and if the patient is unreliable to follow up. Well, that is a matter to discuss some other day. Um, so the benefit of treating to these lower levels with antihypertensive drugs is not established. So you may not overdiagnose and overcorrect unnecessarily. Please take this as a take-home message. Okay, so let's get into the treatment recommendations. Well, I'm again not going to go through the whole chart. This you can share, save it as screenshot. It's condensed and gives you a picture for for you to have it as a reference. So some things I need to highlight. The agents that are there used, you see here, thiazide type diuretic, calcium channel blockers, angiotensin converting enzyme inhibitors, and the angiotensin receptor blockers. Well, these are the four common drugs, like first line target agents you will use. you know so above 60, less than 60, there are different targets that are there. You see, like none of them are like, previously there was a few years back there was a controversial addition to really get the target levels low to as low as 130 and 80 and 90, things like that. Well, that has been taken out now. So again, what we have come back is less conservative approach. So you're going to target in above 860 as systolic blood pressure of 150 and diastolic blood pressure as 90. So you need to get used to this. If you're not getting it, again, you need to watch this video and get a hang of where we're using and or. It's not that difficult, if you are able to logically apply it. But till the time you get it, I would recommend you watch this and or. Okay. So what's going to happen is if you're going to treat him with any of this agent, and the blood pressure comes to consider like the blood pressure was 180 systolic and it came to 120 or 130. Oh, target was only 150, no? Then what you're going to do is, if you attain well tolerated, it is like tolerated by the patient, and then it is less than 140, which was like a previously mentioned target, you can continue to do the same. You don't have to taper off the medicines. Okay. But if the target is not attained, then the target you're still looking for is 150 and not 140. And then less than 60 years. Now, why is this mentioned again? If you look henceforth here, less than 60 is all target is 140 by 90, right? But you need to observe here what is happening here is I have mentioned diastolic blood pressure first. If you look at the staging, I said either systolic or diastolic has to be increased. In younger patients, less than 60 years, the recommendation is to first control diastolic blood pressure, because that is something which has been attributed as a cause for morbidity and mortality in younger patients, to less than 90 millimeter of mercury. And then the next target would be systolic blood pressure of less than 140 millimeter of mercury. Okay, this is for individuals who are less than 60. Then again, given that we are discussing adults, more than 18 years, two common comorbidities, chronic kidney disease and diabetes. For them, the target is, even for above 60, the target would be to reduce it to 140/90. Previous recommendations were even tighter, 130, 80, and 125, 75, things like that. But now it's still like uniform 140 and 90. Okay, and one special mention is any of these things you can go to this agents that were mentioned here. But for kidney disease, you can try to squeeze in, if possible, AC inhibitor or a ARB. Now that reduces the kidney damage. So if the patient has a comorbidity as a kidney damage, you need to find a way, like if you can use AC inhibitor or ARB. Okay, and this is some treatment recommendations for acute emergencies. I've left the agent column blank because my favorite in this is labetalol. In my practice, I have seen that labetalol works really good, easy to administer, and I've very rarely seen a patient who is not responding to labetalol for in any case of emergencies. And why also, see, for heart failure, it is not it is the nitroglycerin, and not the labetalol, that is agent of choice. But still, there is no contraindication among any of these emergencies to labetalol. So if you are a student and who is not aware what to do and you are practicing somewhere else, don't know which agent to use, you can know that there is no contraindication for labetalol for most hypertensive emergencies. So you are safe to use labetalol. Um, And few things, again, these are the commonly asked questions. Hypertensive encephalopathy, someone who is having confusion with axillary hypertension, what are you going to do to him? The target blood pressure here, see, I'm not going to, it will take much time to get a detailed on this. I will tell you a few things. Your target is to reduce 25% blood pressure within minutes to 2 hours. Now, the logic is you are not going to aggressively bring it down to 120/80 or 140/90 because that may interfere with cerebral autoregulation. Your brain, whenever there is an insult, it is with tremendous pressure inside the cranium, which is not letting the blood perfusion to tissues. So your body's autoregulation mechanism is to raise the body's blood pressure so that the blood is reaching the brain. So you aggressively controlling the blood pressure may be causing harm to the brain, more insult to the brain. So you're going to be cautious when you are going to control blood pressure in such patients. Okay, so that's why you have tight values. You will see like your target is you're not going to start blood pressure treatment till the value systolic blood pressure is more than 220 or diastolic is more than 130. And if you're considering thrombolytic therapy, you can't start it before controlling it to less than 185. It's not 160. Its target is still the higher end only. I want to highlight that part to you. And in case of hemorrhagic stroke, the value is little lower, but what it says, it's a range that you need to maintain, where the systolic blood pressure is between 140 to 180. It's not too aggressive again. And subarachnoid hemorrhage is controversial, but still mean arterial pressure is more. They don't see you. You need to observe that they are trying to say reduce, and they have the value saying please maintain it more than 130 millimeter of mercury. Well, these are the whole class of agents that we use and some important points. Well, again, due to I want to keep this session short. Anyway, you can read this. Um, I want to say a few points about this slide. First thing is my favorite thing is calcium channel blockers among all the agents. If you look at the favorite previous slide, the agents I said, most people will tell you need to use the thiazide type diuretic as the first agent. you know but the issue is like with hydrochlorothiazide you can't use higher doses. With chlorthalidone, it has long potence, it has a longer half-life and strong potency, but the adverse effects are more than the hydrochlorothiazide, and you will need two more agents, either like amiloride or triamterene, to counter the effects of potassium loss. Okay, so for that, again, you will end up using chlorthalidone plus possibly another tablet. It's like using two agents again. So instead, you can use AC inhibitor and or ARBs. One thing to mention, most people will ask you is not to be used in combination. Well, but I have found some articles, which says they have been tried in scleroderma renal crisis. There's a condition called acute renal damage that happens in scleroderma, and that is called as scleroderma renal crisis. Their AC inhibitor and ARB have been tried in combinations, but well, still they have been tried, and they're not the first agent. They are beneficial in only such patients, but they are not something which are recommended as a first shot. You will still use either AC inhibitor and a calcium channel blocker or things like that before stepping onto angiotensin receptor blockers. Uh, that's about the combination use. Next thing I would like to say is why I'm talking about calcium channel blockers as the favorite agent. See, many times patient comes to you the first visit and you see is the hypertensive, and you don't have any other laboratory investigations done. You saw the single visit blood pressure is above 180, then he deemed to be hypertensive, and you're doubtful that patient may come to you or not. You may be losing him on follow up. For him, what to give? You may choose a calcium channel blocker, preferably amlodipine, because that doesn't need any laboratory parameters as such. When you're using either AC inhibitor, ARB, or hydrochlorothiazide, you're going to watch for potassium or creatinine. Okay, when creatinine is as high as 2.5, it's like doubtful. You are like, it's difficult to consider AC inhibitors because they can cause hyperkalemia. The same if using thiazide diuretic, which are prone to cause hypokalemia. You may be dealing with a patient who is having secondary hypertension, in some cases where they have hypotension. Oh, sorry, where they have potassium loss to start with. In them, you trying either thiazide diuretic or a AC inhibitor or ARB may cause a complication. So the safest one is calcium channel blocker, and you don't have to prescribe for a long month. You can give it for a period of 10 tablets or so, just as less as possible. After that, once the laboratory parameters are there, then try to shift over to AC inhibitors or other agents depending on the patient's condition. Okay, so that's what I would like to say about the treatment agents. After treatment, there is something called as resistant hypertension. So with regard to resistant hypertension, the first thing I would like to mention is So it's like resistant to treatment. So you're treating the patient as per the recommendation, and what's happening is the patient's blood pressure is persistently above 140 by 90, despite taking three or more antihypertensive agents, including a diuretic. This is called resistant hypertension. The definition. It is commonly seen in more than 60 years. But you may be confusing this resistant hypertension with something which may be showing up as resistant hypertension. That category is, first thing is pseudo resistance. So here the patient may be responding to your medications, but it is only that you are finding a high office blood pressure and still patient having a lower home blood pressures, or there may be other factors to play, like he is not taking treatment properly, or there is a substance abuse, or there are other obvious risk factors for excessive alcohol and obesity, things like that, which may be interfering with your maneuvers to record or with the patient's compliance. Okay, and this is pseudo resistance. So there is no resistant hypertension. There is pseudo resistance. The other condition is pseudo hypertension. So here it's like you are measuring the blood pressure still, and the other factors are taken care of. Still, there is this meets the definition, but it is pseudo hypertension. Where will you find this? In elderly again with severe sclerotic arteries. So your arteries are very much thickened, so that you compress the whole, like when you're measuring the upper limb blood pressure and you compress the whole of the brachial artery, you elevate the systolic blood pressure too much, and you like completely cut off the brachial artery, still you will be able to palpate the uh, radial artery pulse, and that is called Osler's maneuver. That is an indication for pseudo hypertension. Well, this can be used as a substitute when you're trying to find a when you're palpating pulse and you're trying to find whether the arteries are thickened or not. I will tell you about the mechanism how to measure pulse or something the next in some future sessions. But when you're finding them, uh, as a like, oh, am I finding a thickened arterial wall or not? This Osler's maneuver may help you to identify whether the arterial wall is thickened or not in some cases. Well, this comes to this. We're coming to the end of it. We spoke about the treatment recommendations, and you saw like we discussed medicines, but we can't. It's insufficient to just put this slide. It can't be reinforced so much. Even when I was preparing the slide, even I got present that the exercise thing, even I am not following what is recommended. So my promise to you is after this preparation, I'm going to challenge myself and get on the code doing the exercise. And when you're watching this with me, I recommend each and every student here or a person who is watching this to start that habit. Maybe next time in future when you ask me, are you started exercising? Yeah, definitely, I would say yes. Um, okay, so this talks about having more fruits and vegetables and less salt. Clinically, you're going to ask the patient to not use added table salts, no more pickles. Like whatever is there in cooking, that is sufficient. Don't add more pickles and added table salts. Don't do that. That's what the advice is going to be. And well, this is my virtual hugs to you, and stay safe. So I will end this presentation now. We'll get back to the session now. So if there are any questions you have, anything that you need to get clarified, and you have not yet typed, please have it on the screen so that I can answer. If there was nothing, then yeah, we will end the session. Okay. So before we end, I would like to stress one more thing again. So don't overdiagnose hypertensive patients. At the same time, don't miss them. You need to strike a proper balance. The next thing is practicing medicine is practicing when not to give medicines. So I hope you take this message and practice, elevate your practice the way you practice, and the way you are going to be a doctor in the future. Okay, take care, students. Bye.